Good afternoon, everybody. My name is Kevin Hancock, and I am the CHC project coordinator, and I also work for the Office of Long-Term Living and Department of Human Services. The purpose of today's webinar, as seen on the slide in front of you, is to provide technical assistance and training on older adult and adult protective services. The speakers today will be going through a great deal of detail on the protective service programs that are operated under the direction of the Commonwealth of Pennsylvania's Department of Aging and Department of Human Services. They're going to be going into a tremendous amount of detail on why these services are critical to the health and safety of participants receiving services in our programs, as well as those who are in need of services for many of the programs offered by many of the agencies, including the regional area agencies on aging and also Centers for Independent Living. Our goal today and the takeaway is to talk about these services and talk about the laws that authorize these services, and also to translate that goal into managed care environment. Many of the participants on the call either are working directly for some of the community health choices managed care organizations, and in many cases, some of the participants are working for our life plans that exist across the state. The hope is that after the presentation, there'll be a great deal of interaction where a lot of questions may be answered on how protective services will fit into the model of managed care, and to make sure that it's very clear what are the reporting requirements for these types of services for managed care organizations. In addition to all this, we will also be mentioning and going through some detail about the critical incident reporting process, and that's specifically for community health choices, but it would be good background for the life programs as well. And with that, I'm going to be turning it over to Denise Getchen. Denise Getchen will be providing the background on older adult and adult services. Thank you, Denise.
Thank you, Kevin. Hi, everyone. Before we get started, I wanted to just go over a few items so you know how you can participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. As a reminder, you're all muted. To the left is the GoToWebinar viewer through which you'll see the presentation. To the right is the GoToWebinar control panel where you can ask questions and select audio mode. If it is the control panel is closed and you just see the slim red rectangle, click on the red arrow to expand it. You're listening in using your computer or system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. If you will be placed in listen-only mode, again, you'll have the opportunity to submit text questions in today's presenter by typing your questions to the question pane of the control panel, so you can send your questions in at any time during the presentation. Okay, so again, my name is Denise Getchen. I'm the Director of Protective Service Office at the Pennsylvania Department of Aging. Joining me is my colleague Laura Dietz, the Adult Protective Service Director with the Department of Human Services. We're going to be discussing adult protective services, which is protective services for individuals 18 to 59 with disabilities, older adult protective services, which is age 60 and above. And of course, the purpose of the webinar is to really introduce the MCOs to protective services. We're going to discuss the common themes of these two laws and point out some subtle differences as well. We want to talk about your responsibilities under these two laws, such as background checks and mandatory abuse reporting. Again, please submit any of your questions that you have during this webinar through the question box. I want you all to know that we intend to provide further operational information in a second protective service webinar, which will be held in November. During that webinar, we'll get into more detail about cases and the absolutely necessary collaboration and communication between the MCOs and the area agencies on aging, in particular the protective service units. At the end of the presentation, we've provided for you 2 resource accounts that you may email if you have further questions or concerns, anything that wasn't addressed in this presentation, or you would like specifically addressed in the next webinar. Okay, I think we're ready to get started with just the presentation. And what I'd like to do is talk about how the program works in both APS and OPSA and what are the common themes with these two laws. So in both adult protective services and older adult protective services, both programs provide for the detection, prevention, reduction, and elimination of abuse, neglect, exploitation, or abandonment. I just want to call to your attention that it is not just about investigating allegations, but the legislature intended that we indeed look to detect abuse, but we do some prevention work around this area, working with all of you towards prevention, but it's most important that we reduce or eliminate abuse. So this whole programs are both about serving adults with disabilities and older adults. Both programs require a uniform state reporting system. They both prescribe penalties for failure to implement the laws. There is in both laws voluntary and mandatory reporting requirements, which we're going to talk about in depth. And both laws call for utilizing the least restrictive alternative in the most integrated setting. Both talk about the rights of individuals, of course, as in any of your programs. Older adults and adults have the right to make choices regarding their lifestyles, relationships, their health, their bodies, and even when those risks or when those choices present risk. They have the right to refuse an assessment. They have the right to refuse some or all of protective services. And the last bullet there talks about what happens when some of those kinds of things happen. The two laws provide for court intervention when and if necessary. So the laws read that when there's clear and convincing evidence that if protective services are not provided, the adult is at imminent risk of death or serious injury or serious bodily injury, the agencies may petition the court for an emergency order to provide those necessary services. So generally speaking, people have the right to refuse and to refuse to accept services through either adult or older adult protective services. However, if we feel or if we determine through our investigation that someone's at imminent risk of death, serious injury, or serious bodily injury, we can go to court for a court order to access and to provide service.
As Denise said earlier, with adult protective services and older adult protective services, we're dealing with two distinct laws. They have many similarities, yet many differences. So what we want to do is kind of point out some highlights for both laws and talk about the eligibility. What you see on your screen is for adult protective services. And adult protective services, as Denise already said, has the legal authority to investigate any allegation of abuse, neglect, exploitation, or abandonment. This program oversight is with the Department of Human Services, and we also provide the funding. The local area agencies on aging take all reports of need for anybody between the ages of 18 and death, and then those for the individuals within adult protective services are submitted to Liberty Healthcare for investigation. In order to determine whether an adult is in need of protective services, there's specific eligibility. They must be a resident of the Commonwealth of Pennsylvania. They must be between the ages of 18 and 59, that have a physical or mental impairment which substantially limits one or more major life activities. And the adult also must require the assistance of another person to obtain services to prevent the risk to their person or property. So these, what you see on the screen now is specific for the individuals between the ages of 18 and 59. Now we're going to go into, let's just think, so that Laura just talked about adult protective services. Now let's flip to older adults. So although these laws are very similar, there is some subtle differences. And like I said, I want to point out just some of those. Our eligibility for people age 60 and above is very similar. Ours are, they have to be a person within the jurisdiction. So as Laura said, in adult protective services, they're a resident of the Commonwealth, but in older adult, they're a person within the jurisdiction. So again, just a subtle difference. They have to be incapacitated, unable to perform or obtain services necessary to maintain physical or mental health, for whom there is no responsible caretaker. And I'll talk about that as we move along this webinar. And who is at imminent risk of danger to their person or property.
So again, the Department of Aging oversees older adult protective services. Eligibility is pretty similar.
Now we want to discuss with you the referral process. The unique thing that Adult Protective Services and Older Adult Protective Services were able to do was provide for one hotline where, regardless of age, you would be able to report your concerns of suspected abuse. As you see there near the top of your screen is the 1-800 number, again, that you can call regardless of the person's age. Once a report is received by the local area agencies on aging, they will complete what is called a report of need. This is a document that has certain information that's required for individuals reviewing it to determine whether the individual needs an investigation or not. The individual on the other line will ask specific questions to gather that data for you, but items you may want to make sure you have is demographics, address, perpetrator access to that individual, disabilities, any mental health issues, and of course, specific information related to the concerns that you're calling in. Now, further on in this webinar, we'll talk a little bit more about mandated reporter, but if there is an allegation that rises to the level of a suspicious death, a serious injury, a serious violent injury, or sexual abuse, individuals who are mandated reporters must also contact law enforcement and a point of contact within the Department of Aging and the Department of Human Services. So once that report of need is received by the AAA, if the individual is between the ages of 18 and 59, that referral will be immediately sent to Liberty Healthcare. Liberty Healthcare evaluates that report of need to determine if they meet the criteria and then categorize that case according to those allegations. If an individual is residing or receiving services from a licensed facility, through a licensed facility or another program offices, they will also make those appropriate notifications. For OAPSA cases, for individuals who are over the age of 60, the AAA staff, the local area agency on aging, will determine if they meet the older adult criteria, categorize it, and again, notify licensing, just as Liberty Healthcare would. If they're determined that there's no need for investigation, they will make appropriate referrals for that individual. All Adult Protective Services cases have the ability to be categorized in 3 different categories. As we said before, no need for investigation, non-priority, and priority. Based on the level of need, an individual whose case is identified as a priority will be responded to within 24 hours. A case that is identified as non-priority, the investigation will be initiated within 72 hours. For cases that involve individuals over the age of 60 within OAPSA, there's an additional categorization, which is an emergency, which means that case will immediately be initiated upon receiving that telephone call. So that's a little bit of a difference between the over and under 60 program is the additional categorization for the immediate response. The initiation of an investigation will begin within the required time frames, determine if the individual is at risk in the need of protective services, and then if services are necessary, they will be put in place to mitigate that risk. Those programs may also provide for additional services intended to assure the individual's safety and well-being. And again, I kind of want to go back and just, it's a lot of information in a few slides, but the referral process in a nutshell means you will contact the same 1-800 number regardless of the individual's age for both programs. Those reports will be received by the local area agency on aging. Then they will determine the individual's age and either refer it over to Liberty for investigation or maintain it within that AAA, or if the individual resides in a different county, refer it on to them. So the process has been designed to be as easy and painless as possible for everyone involved, so it can be streamlined for both programs.
So I just want to go just quickly over that, just to sort of give you just a bird's eye view of how this works. If you suspect abuse, you call the 1-800 line. It's answered by an area agency on aging. The area agency on aging will ask you a lot of questions, some of which you'll know, some of which you may not know. give them all the information that you could possibly obtain or give to them. They're going to be asking you, of course, Laura mentioned demographics. They'll be also asking you about maybe their cognition, if they're able to make decisions, who do they have in their life, like an emergency contact or a physician, who's involved with this person that you know, and of course, what are your concerns? Very specific detail is very helpful to protective services. So the more detail you can give about what the abuse, neglect, exploitation, or abandonment is, the more helpful that is to the investigator. So once that case is received by the Area Agency on Aging, they fill out what we call a report of need, which is like our intake form. Then it goes to protective services directly, who will determine if an investigation needs to occur and how quickly. So they're going to prioritize that case. And then once they determine that an investigation, they will be sending out an individual out to see the adult or older adult, and an investigation will be completed. So our investigations are required to be thorough and comprehensive, so they may be contacting you as part of an investigation. Maybe it didn't start with you, but if they get an allegation that includes someone or is about someone who may be receiving your services, you may get a call from protective services asking what kinds of services you're providing or what information you can provide to them about what may be happening in a home or those kinds of things. So you'll be involved in the investigation. The investigation may include contact with a physician, a neighbor, a friend, family members, powers of attorney, and anyone else who may have been eyewitness to something or may have knowledge, firsthand knowledge about a situation or an allegation. Once the investigation is completed, it goes to what we call a determination. It's either substantiated, meaning the adult or older adult is in need of protective services, or it's determined to be unsubstantiated, meaning the older adult or adult is not in need of protective services. If someone is not in need of protective service, that doesn't mean that we don't do anything. There may be other services, for instance, your services, that they may be eligible for or interested in. So we may be making referrals in that manner too. So if they are in need of protective services is required then by law to implement a care plan, develop and then implement a care plan, of course, with your participation if you're already involved in an individual's life. And so we may be asking for you to share with us your plan of care, and so we can either build upon that or make some revisions or collaborate with you about what we think would reduce or eliminate risk. So those are the kinds of things. Once that happens, we're required then to implement these services and then come back at a later date to determine were those services adequate to reduce or eliminate the risk. So I hope that gives you just a picture, a general picture of how protective service works. Laura already talked about categorization. Again, just a little subtle differences. Older adult has emergency, and APX does not have that categorization. Generally speaking, I would say that cases are started anywhere from immediately, in both programs, immediately to up into 72 hours. And again, as Laura said, if a case is determined or categorized as no need, that means for us that either the person doesn't fit our criteria. For instance, in older adult protective services, if someone lives in New York, they don't meet our criteria. However, that doesn't mean that we just say, oh, I'm sorry, you're in New York, call there. What we do is try to do a warm handoff to New York Protective Services. Or if somebody was under the age of 60 and they were calling older adult protective services, it would be no need for older adult, but we would share that, of course, with Liberty as the under 60 investigative body. So if they don't meet our criteria, or for some reason they're determined an investigation is not determined, maybe the person's not at imminent risk, or they have a responsible caregiver who has already done what needed to be done, there's nothing more that can, sometimes we get calls from the participants themselves, and they've already taken care of whatever the issue is. But for whatever reason, if something's determined no need, we do make proper referrals to other service providers. Next, I want to talk about mandatory abuse reporting, and I know all of you on the webinar are interested, and just generally speaking, you are all mandated reporters in terms of many of you, I should say, I shouldn't say all because I'm not sure exactly who all is on the call, but certainly direct individuals who are working through what we call a facility as defined by our law. And so the law is both laws talk about facilities being nursing homes, personal care homes, dom care, daycare, those kinds of home health care agencies. But both laws, if you look at the definition of home health care agency or in the APS law, there's a very broad category that talks about a private or public entity or part of that who provides care to a care-dependent person in their place of residence. And so many of you on this call fit that definition either through the APS direct bullet or through the home health care definition in the Older Adults Protective Service Act. So many of you are mandatory reporters, and I want to talk just a few minutes about what that means. So again, when I'm going to go through this, so I say the first bullet there says an employee or an administrator, and it implies of a facility, so that's where you fit in. An employee or an administrator of a facility as defined who has reasonable cause to suspect that a recipient, any age, is the victim of abuse shall immediately make an oral report to the Area Agency on Aging. And again, Laura referred to the 1-800 line for any age. So you suspect abuse, you're to make an immediate oral report to the Area Agency on Aging. The report is to be at the time of the incident, not after you do your own internal investigation or care planning sessions or interdisciplinary meetings or team meetings. It's to be immediately upon identification or immediately when you suspect abuse, neglect, exploitation, or abandonment. So again, your internal investigation does not replace protective services nor does a licensing review. So when we go to the next slide, who must report? Of course, an employee. An employee is defined as an individual who's employed by a facility, and again, referring to that definition of facility. It does include contract employees who have direct contact with residents or unsupervised access to their living quarters. The term also includes persons employed or contracted to provide care to a care-dependent individual for monetary consideration in the individual's residence. And of course, an administrator, and I think we all know what that is, the person responsible for the administration, again, of a facility as defined. And it does include the person responsible for employment decisions or an independent contractor. This is maybe the most important slide. So here's what happens. You suspect abuse, you call the Area Agency on Aging. So there's oral reporting. So who is to orally report? An employee or administrator. What are they to report? Any suspected abuse immediately, orally, to the Area Agency on Aging. If that abuse rises to the 4 serious, what we call the 4 serious abuses, and again, those are sexual abuse, serious physical injury, serious bodily injury, or suspicious death, then you have additional reporting requirements. You are to report to the Department of Aging for individuals 60 and above, and to law enforcement. For individuals 60 and under, you would report to the Department of Human Services. Within 48 hours of those oral reports, you are required then to provide a written report. Again, employees or administrators who suspect abuse, within 48 hours of your oral report, you are to submit a written communication to the Area Agency on Aging. The AAA then submits to PDA or to DHS in each program. And then, of course, you have to follow your report to law enforcement with a written report as well. I want to talk about the definitions of sexual abuse, serious physical, serious bodily, and suspicious death. Now, again, just to reiterate, these are what we call the 4 serious. If the abuse that you're reporting or you suspect rises to one of these, you have these additional reporting requirements. So it's important that we all understand, especially the first bulleted one, the sexual abuse. And just to give you a sense of that is, the sexual abuse, as it's defined under the law, is really the very serious sexual abuses. So it's definitely different than sexual harassment. So sexual abuse generally is any of the intercourses. So intentionally, knowingly, recklessly causing or attempting to cause rape, involuntary deviant sexual intercourse, sexual assault, statutory sexual assault, aggravated indecent assault, or indecent assault or incest. So Those are the big and typically involve intercourse. Sexual harassment, that is something very different, and again, that's, you know, as an example, that may be unwanted verbalizations to someone. These are the ones where someone kisses someone else, those kinds of things that don't rise to this level. Serious physical injury, I think we're all pretty clear, but that is, it causes a person severe pain or significantly impairs a person's physical functioning, either temporarily or permanently. Serious bodily is more of the serious one. It creates a substantial risk of death or serious permanent disfigurement or protracted loss of a function of a body member or organ. And then, of course, suspicious death. Suspicious death is not defined in the laws, but I think it's clear. Anything unplanned, unexpected as a result of things like falls or medication omissions or overdoses, those kinds of things. So those would be just some examples of suspicious death. So just to give you just sort of how this happens, so you suspect abuse, you call the area agency on aging, it's one of these 4 serious, then you have these additional reporting requirements, and I just wanted to make sure that you had the number for those additional reporting requirements. And when you call this line, you'll get 3 options. One is for criminal history record information or questions. Option 2 is for over 60, and option 3 is for individuals 18 to 59. For employees who may have allegedly committed abuse, a facility, again, as defined, all of you or many of you on this call, you can either immediately suspend your employee or you can put this employee under a plan of supervision. However, if you plan to use the supervision, it must be submitted to and approved by the area agency on aging and a facility's licensing entity. So both have to agree. Upon any filing of criminal charges against an employee, the licensing entity, the oversight body shall order a facility to immediately prohibit an employee access to the recipients, and the director or an administrator or a supervisor should immediately act to ensure the safety of all recipients.
I'm not going to go over every example of a mandatory reporter as they're listed in front of you. And I think for the individuals on this call, clearly at the bottom is, I think, where we catch these participants. An organization or a group of people that uses public funds and is paid in part to provide care and support to adults in a licensed or unlicensed setting. So as Denise has already gone through all your additional reporting requirements, the Department of Human Services provides a webinar which gives more detail on the steps for the Under 60 program. Anybody who is interested in participating in that webinar can register on the Department of Human Services website. You just locate the Adult Protective Services page, and then there's a link where you're able to register. We try to hold those on a monthly basis and at varying times during the day, so individuals can be afforded that opportunity based on the hours that they may work. But again, if you want more information, please access that on our Department of Human Services website.
The next page is just, or the next slide is just, again, OPSA's mandatory reporters. I'll echo what Laura said. You can see that home health care organization or agency is one of these, and that's sort of our catch-all that mirrors the bullet that Laura just shared with you. The next set of slides, I just want to warn everyone that some of these, oh no, these are, we're good. We're going to be showing some, I want to talk about some signs and symptoms, but we're also going to be showing some pictures, and I just want to warn everyone that some might be a little graphic. We don't do that for shock value, rather we want everyone to understand and fully recognize the serious abuses that we're seeing in the community and through facilities. So, talking about signs and symptoms, behavioral, so what might you run into as you work with adults of any age? And so what we're seeing based on the statistics that we gather through protective services and adult protective services, some of the things you may come across are adults who out and out come out and tell you that they've been the victim of abuse, neglect, exploitation, or abandonment. Or on the flip side, or conversely, they deny that there's a problem despite clear evidence. So someone may have a very obvious injury, but and describe the way that it occurred, but it's clear to you and to everyone that it couldn't have occurred that way. So they may deny the problem despite this evidence. You may see repeated stress-related complaints, illnesses, things like depression, confusion, multiple trips to an emergency room, that kind of thing. That could be a sign and symptom of abuse. Refusals of care. We've certainly had cases where individuals refuse to be undressed because they don't want anyone to see bruises or injuries that they've suffered as a result of abuse. And so refusal should be looked at very, very seriously and trying to really get to the bottom of why is an individual refusing care and services. You may see poor personal hygiene, maybe a change in this area. You may see increased or new incontinence. Oftentimes, victims protect their abuser, and I think we all recognize why that might be. These people are very dependent in a lot of cases for care and services, for shelter, for food, for any kind of interaction. They may fear being institutionalized. They may fear for their physical safety, that kind of thing. And so very often they'll verbally act or speak in ways that protect the abuser. We may see also that they remain silent or they wait for their abuser to answer questions. So you're talking to someone, of course, protective service tries to interview individuals alone and confidentially, but you may be talking to someone and you notice that they wait for their abuser or their caregiver to answer all questions, or the caregiver takes over questions and answers and those kinds of things and doesn't allow someone to respond.
We're going to move forward and also talk about some of the key characteristics you may see as far as the caregivers. And a lot of what Denise said earlier, as far as they can be older adult or the adult and the caregiver being in the same room, the things you may be looking for is the caregiver is constantly talking on behalf of the adult and not allowing the adult or older adult to speak on their own behalf. It may be the eye contact that caregiver places on the adult, the subtle things that is clearly demonstrating that individual doesn't have control over the conversation, that the caregiver is controlling that for them. Oftentimes we see these individuals having some level of a psychiatric history or substance abuse, which is directly inhibiting the care for that in the older adult or adult. These individuals will isolate them. You'll see a change in behavior that maybe the adult or older adult used to attend church on a regular basis, and over a course of several months, you don't see them. So, or they used to come into the office to do their own paperwork, and now, the caregiver may be saying, well, they're too sick now to come in, or it's difficult for them to ride in the car, so I'm coming in to do this on their behalf. So those are some of the things that you may see happen with your interaction with these individuals.
In terms of signs and symptoms of possible financial abuse or financial exploitation, in working with individuals, you may see or become aware of sudden changes in the adult's financial status. You may see personal items, or someone may confide in you that their personal items are missing. Changes in wills or powers of attorney, or titles to vehicles and homes, those kinds of things. Addition of names on the older adults or the adult's bank card or their ATM card. Unpaid bills, you may become aware that there's a stack of unpaid bills, or you go to a home and there's notices of shut-off notices, those kinds of things where you say to yourself, that doesn't seem to make sense. Maybe this individual was a teacher their whole life, or maybe they were a state employee, or they have some kind of Social Security or pension or some other income that just doesn't make sense. And in a lot of these cases, it's just your what we call gut feeling that something doesn't sound right or it doesn't feel right. And sometimes it's not just one thing, but it's a bunch of things. Some are subtle, some are not so subtle. So, when we're talking about things, we're just always reminding everyone to just be diligent and to be looking for the things that you just say to yourself, that isn't right, or that didn't sound right, or that didn't seem right. We see multiple cases, especially right now with online banking. So in the older adult world, we have an 85-year-old older adult who has never used a computer, and we see a lot of online banking transactions and money moving online. And so not that the older adult couldn't, but they typically would not be using online banking and moving money and assets and those kinds of things. We also see a lot of ATM transactions where someone's going to an ATM machine multiple times a day. And so it just doesn't make sense with this person's pattern or with their abilities.
Moving on to some of the physical symptoms that may be something that you may see. I think we're all aware that to look for those unexplained signs of an injury, such as bruises, welts, scars. Sometimes we also look into the symmetrical injuries on both sides of the body that may indicate that there was some type of restraint utilized. There's broken bones, sprains, or dislocations. And I want to point out that a lot of these is the story that you may be hearing from either A, the caregiver, or B, the individual themselves are just not making sense. It's not adding up. Could be a direct indication that they're covering up something. It's also important to know that there also can be overdosing of medication as well as failure to provide that. Sometimes it's a form of control with the medication, or it's just the caregiver does not feel that the individual requires that medication. Oftentimes, there could be repeated incidents into the ER, the constant day after day for the same thing. It's healed up at the hospital, and then we see these individuals go back to that same caregiver, and a few days later, the same issues are arising again. So there's repeated visits to their regular doctor or their ER. And also just a flat-out refusal, like we said before, to see that individual alone. And sometimes, looking through medical records, some of these things may just come to light when you're reviewing them. So if it doesn't add up, it could be an indication that this individual is being abused in some way.
In terms of sexual abuse, and just to give you just an idea, this type of abuse is the least common that we get reported, although frequently in facility-type settings, we do see a fair amount. A lot of what we see, bruising on the inner thighs, difficulty walking or standing, pain in the pelvic area. We've had individuals show up to an ER with a sexually transmitted disease or infection when clearly they're not and have not been for some period of time sexually active. We may come across, you may be a provider who goes in or an individual who goes in to provide direct care and services and find someone with torn, stained, or bloody undergarments. That doesn't make sense. Their bedding may be soiled as well. We see unexplained anal and vaginal irritation, injury, or redness. A lot of times these people are showing up with these types of injuries. We've seen a fair amount of inappropriate sexual relationships between the victim and the alleged perpetrator. And again, when you start thinking about protective services, generally speaking, perpetrators, not that anyone can't be a perpetrator, certainly anyone can be, but oftentimes they're family members or they're caregivers. And so when you start to see an inappropriate sexual relationship between the person you're serving and another person, again, that gut says that didn't sound right, that didn't look right, something's not right here. And the last bullet talks about inappropriate, unusual, or aggressive sexual behavior on the part of the participant or the alleged victim. And so those may be some of the things you might see if someone is being sexually abused.
Just for caregiver neglect, some of the things that you would want to look for is unusual weight loss that's unexplained by health diagnosis, malnutrition, dehydration, poor hygiene where individuals in a care plan are to be bathing them X number of times a week, and that they're coming in constantly to the doctor's office, dirt under their fingernails, dirt on their clothes. We will see them be able to get access outside the home and be wandering down the street, or sometimes the caregiver, when they will leave, will inadvertently lock them in the home to keep them from preventing to get them out. We see bed sores because individuals are not following care plans for either repositioning or getting them even out of bed and into a chair, into a different position. We have seen conditions within the home where a caregiver is being paid to provide care. The home, when you walk in, looks immaculate, and then when you go to the room that is assigned to this individual, there are feces, there is garbage, there is trash, there is human waste, because they're not taking care of the space that's provided to this older adult. And that goes also into the unsafe living conditions. If an individual isn't able to access the upstairs, and that's where the individual's bedroom is, or the only working bathroom, it's unsafe for them to travel up and down those stairs, and not providing them with some type of alternate situation to be able to use a different restroom or some type of another assisted device.
Self-neglect, and some of these, this is the #1 reported allegation of abuse that we received in Pennsylvania. So we do see a large amount of self-neglect, and I'm sure you will as well, or you do on a regular basis. So what could be self-neglect? Refusal. That's maybe the biggest one we see. We have a lot of individuals out there who refuse medications, they refuse bathing, they refuse activities, transfers, change in position, meals, etc. So you develop a care plan with an individual, or for whatever reason you're providing services, you have a plan of care, and they're refusing. And so I just want to make sure that everyone, there's a difference between refusing a bath one day, which certainly we all have done. Gee, I really don't feel good today, I'm going to just stay in bed, or I'd like to sleep a little bit later, I'll get a bath tomorrow, and that's one thing. But when someone is refusing care and services to the point where there's a health and safety risk, those are the kinds of things that can rise to the level of self-neglect and should be reported. Not so much that someone didn't want to take Tylenol, but when someone starts refusing, turning and repositioning, and they clearly cannot do that on their own, or medications like insulin, or seizure medication, those kinds of things, when they start refusing those, we have to pay really close attention to that and make sure that we're reporting. Poor grooming, I think Laura talked about that, and their appearance, soiled or ragged clothing, dirty nails, skin, that kind of thing. I think you guys are familiar with that. Isolation, where they're either self-isolating or they're being isolated by another individual. Lack of social supports is another concern. Disorientation, confusion, and again, we see alcohol or drug dependence. And so those are just a few of the signs of self-neglect. You may be familiar with others, obviously, but we just wanted to give you a sense of maybe the bigger things and the more frequent things we're seeing in both adult protective services and older adult protective services.
So it would make our lives a lot easier if there was a typical profile that we could identify these individuals who may be abusers, and unfortunately that doesn't exist. But we have statistically been able to gather some information that are some key indicators that this individual may be abusing another one. As we have said before, we've talked about the abusing of alcohol or drugs, having some type of mental health history, previous criminal history, obviously blaming the individual that this situation is their fault, and in initiating that step into isolating them from individuals that have been consistent in their lives. So cutting them off from the access to the rest of the world, dependency on them for just emotional support, or even that financial piece, that it's time now that we have them move into our home because I may no longer have my employment and I need that Social Security in order to sustain my living environment. So we've really covered a lot of these when we talked about the profile of a caregiver. So I think Liz taking a look at these, and these are the key kind of indicators that there may be a situation going on and there may be some level of abuse.
Again, the next slides are a little graphic, but we did want to show you the serious nature of what we're seeing on a regular and consistent basis. we've had these slides came from individuals who were receiving services. So we just want for everyone to understand that despite anyone receiving services, there are still concerns out there and abuse ongoing, neglect, exploitation, and so no one's immune, I guess is the whole point. So if we can, this is an individual's home, and clearly I think you can see that there's literally a tree growing through the home. There was essentially no roof, and this is an individual, again, who is someone who's accessing services or reaching out for services. So the key to this is, I mean, we certainly don't want to hold responsible people who are doing the best that they can, or just determine someone's in need of protective services based on an environmental alone. But what is so important is determining, does that environmental issue impact the health and safety of the individual? Because sometimes certain environmental things are out of the control of another individual. Sometimes it's a lifestyle choice about how people choose to live their lives and in the environment in which they choose to live. However, when it reaches the point where it impacts the safety or health of an individual, those are the kinds of things where protective service does get involved. The next slide is a hoarding. Many of you may have seen these shows on, they come on in the evening about hoarding. This is not something that's an easy fix. This is typically mental health involved issue. And so this is not something easy that we can fix overnight. It's a very difficult concern for protective services to try to work on. However, there are services available through protective services. Things like we can work together, we can collaborate on cleanup or infestation or counseling, those types of things that can over a long period of time may be able to help these situations. Again, we want to look for how does this impact the health and safety, because that's what we're all here to ensure, that these individuals receive the care and services that are necessary, but also that maintain that health and safety. This next slide is a 40-year-old individual who resided at home with family, with a husband, but you can see that clearly there's soiled bedding, there's soiled, there's species, soiled mattress there. This individual is extremely thin. When protective service got there, this individual only had access to 5 unopened Pepsis. And so you can see, start to think about, these are caregivers who are and family members who are responsible for the care. This person had no ability to open Pepsi at the time. And so this actually is a success story, because this person was, unfortunately, had to be removed and hospitalized, but did regain her strength, weight, and was able to, again, regain access to her children, and did very, very well. And so, this case was an interesting case, because not only was this, Laura kind of alluded to this just a minute ago, but it was not only a self-neglect, because there was some refusal in this case for sure. There was also a caregiver neglect. It was an environmental concerns as well, but there was also an underlying financial exploitation, where the family and that environmental family structure did not want change, because this individual had income. And so they didn't want this person, they were very reluctant to reach out for care and services, nursing home care, facility care in any kind of facility. And so we're always looking under protective service, not just for the allegation that comes in, but what's underlying that. And a lot of times we see that that is a financial component. This next case, and I know, I'm sorry this is graphic, but this is an individual who, again, residing in the community, and literally had grown, the springs of the bed had grown in and through her skin. This is an individual who was reliant and dependent upon others for care and services. And so you can see, and you can imagine how much pain and suffering and just the general concern that protective service had with this case, even though, again, there was some component of refusal and lack of knowledge on the part of a caregiver. And so These are really serious cases that can absolutely lead to the death of adults and older adults. Unfortunately, that can happen very quickly when individuals aren't getting adequate care and services. So those are the kinds of things, and those are, kinds of the things that we're seeing very frequently. And so we just wanted to share some of that with you so you get a sense of what you might see. Again, I want to talk about our 1-800 line. So this 1-800 line is what we call a phone tree. So for instance, if I'm sitting here in Dauphin County in my office and I call that line, I will get Dauphin County Area Agency on Aging. If I'm sitting at my house and use my home line and call, I will get York County Area Agency on Aging. If I'm in Allegheny County and I call that line, I'll get Allegheny County Area Agency on Aging, and so forth. However, please understand that if this phone tree cannot recognize where you're calling, we have set up a default, and you may get Allegheny County. That's by design. We have asked Allegheny, and they've graciously agreed to take some of that overflow. And so if you get Allegheny County, don't panic, just give them the information. They will get your report to where it needs to be. And typically that is the closest area agency on aging to where the alleged victim is residing or is located. And so there's our 1-800 line. And I just want to say that we give this line out a lot because you could call the area agency on aging directly. Some of you on this call may have a good working relationship with the area agency on aging, and you call them directly. You know how to get the protective services, and that's great. We advertise this line a lot because for ease of use. So we didn't want to be on this webinar talking about call every different number, but this is just an easy click so that if some people have multiple locations, that they can give this number and you can call just one and remember one line. So again, feel free to call the area agencies on aging directly. This 1-800 line is staffed 24/7, 365 days. There may be some things just to talk about how this line works. So if you call this line and it's after hours on a weekend, night, holiday, those kinds of things, you may get the 911 center of the county you're calling from. That's because the area agency on aging may have a contract with them. So they will take either your call or they'll hook you through directly to a protective service investigator, or they will have the investigator call you back very, very soon. And so it may be a little different in each county, but again, if you call this line and you ask for whoever's on call for protective services, again, if this is after hours, weekends, holidays, nights, that kind of thing, you just say, I'd like to talk to whoever's on call for protective services. They will get you in contact directly. Okay, the next part, so let me just stop there for just a moment, and I just want to quickly go back through. So under adult and older adult protective services, there's voluntary reporting, and so I just want to share just a second with you about that. So I'm a person in this world. Forget that I happen to be a registered nurse in the Commonwealth. Forget that I happen to work work in a nursing home. Forget that I work for the state, wherever I am, but I'm just a person in this world. Any person can report under these laws, and they can report anonymously. So that's the voluntary section. And the process is the same. They suspect abuse. They're concerned about their neighbor. They've lived next to their neighbor for 12 years. Their neighbor always comes out and gets the newspaper, always talks to them, goes to lunch with his or her friends. Their nephew moves in, no longer can they get their medicine. They tell you they can't afford it. They're not driving their car anymore, and the nephew's driving the car. The nephew has people in and out all hours of the night. You hear yelling and screaming. You see some bruises. You're a person in this world, and for whatever reason you're concerned, you suspect abuse, you can report. And again, the process will be followed. It'll be categorized. There'll be an investigation if necessary, and there'll be services to put in if the case is substantiated. So that's one piece of older adult and adult protective, which is just a voluntary reporting provision. And again, those individuals can be anonymous. Then we already talked about mandatory abuse reporting, where you're seen as a facility under the law, under the laws. Under that, you are not anonymous. You are reporting as required by the law, and so you would give them your information in terms of where you work and what's your title, those kinds of things. The third part of older adult protective services is the criminal history background check provision. And so we're going to spend just a few minutes on making sure everyone understands criminal history background check requirements. So under Older Adults Protective Services, every person and whoever's going to be employed by a facility, again as defined, all individuals get a Pennsylvania State Police check. That is handled by the employer. So the employer goes on ePatch, they get the person a background check through the state police, they look at the results of that background check and they make an employment decision. If the employee has lived outside of the state of Pennsylvania or lives outside, has lived or lives in the past 2 years outside of Pennsylvania, then they need, in addition to the state police check, they need an FBI check. So again, this is a requirement of the law, and these FBI checks are processed through the Department of Aging. There can be provisional hiring, 30 days if someone needs the PSP check only, 90 days if they require both the PSP and the FBI check. Again, those provisional hiring periods can be put into place if the 3 things listed below are in play. So the applicant, obviously, the applicant has to have applied for a background check and has provided you documentation with that's true. The applicant swears and affirms, and this is typically on an employment application. They swear and affirm in writing that he or she is not prohibited in any way from providing services. And then the administrator has no knowledge or information that would disqualify for any reason the applicant from employment. Now I want to talk about what we refer to as peak. So in December of 2015, Commonwealth Court held that this part of the Older Adults Protective Service Act was unconstitutional. And what it basically said was the lifetime employment ban violates due process guarantees under the Pennsylvania Constitution and therefore is not enforceable. The interim at that time, so that happened in 2003 and again in 2015. In 2003, we put into place an interim policy, and we talked about how we could sort of continue with background checks, but there were some provisions made and an interim policy was put into play. When this happened in 2015, they said no more of that interim policy. Again, it's invalid. So the next slide, I just want to share with you what needs to happen. So background checks are still required by all applicants. But what's happening right now are facilities. So again, as defined by the law, must and do make the employment determinations. And what we've asked is that you, when you get the background check results, that you consider the following: the nature and the facts of the crime. So what happened, and you can talk to your applicant about that. What happened and what was the nature of this crime? How long ago was this crime? Are we talking about something that happened 2 months ago, or are we talking about something that happened 12 years ago? What is the evidence of rehab? What has that person done to prove that they are an appropriate caregiver since that conviction? And then what is the nature and the requirements of the job that you want them to do? For instance, if there's an individual who is never going to drive for you or have any part in any kind of transportation and that kind of thing, and the individual maybe has a DUI, you would have to consider whether you want that person. And that holds true no matter what the conviction is for. So say someone has a theft conviction. You would have to look at the background check, determine that they have a theft conviction, and then you have to determine, based on these things, whether you want this individual to be an employee. And so what we've done is just put some of these prompts out on our website to make sure that when you're making these employment decisions, we have a few recommendations that maybe you consult with your risk management or an attorney prior to making any employment decisions, that you consider, again, these factors: the nature of the crime, the facts surrounding the conviction, how much time has elapsed since the conviction, any evidence of the person's rehabilitation, what kind of work have they been doing, what have they been doing in the meantime, the nature and the requirements of the job, and the performance of the individual So if you have any questions about that, I mean, we're certainly willing to help you to think through, or to help you if you had some questions about what you're seeing on a background check. But again, we would say many of you have attorneys available and resources available to look some of this up. But if you have questions, we certainly want to provide you with our phone number there.
In the event that you would be involved in an adult protective services case for individuals between ages of 18 and 59, the investigations are conducted through our current state contractor, Liberty Healthcare. And this slide provides you with the contact information of the key players. You have the statewide director. The state of Pennsylvania has then separated into 3 specific regions: the West, the Central, and the East. Each of those regions has its own program manager as well as a set of supervisors. So in the event you are involved in a case involving an individual between the ages of 18 and 59, these are the key players that you would want to reach out to if you have pertinent information you want to get to an investigator.
Again, please note that we intend to provide further operational information in a second Protective Services webinar, which will take place in November. Again, in that webinar, we want to get into such detail, things like when Protective Service goes into a home and the reporter did not know or didn't report that the consumer was enrolled in CHC in some getting services, how would PS investigator know that? How would PS Protective Services know who the sports coordinator is and how to contact them? What information should be shared between either an SC, the MCO, and Protective Services? Is Protective Services HIPAA exempt? Who is the actual mandated reporter? These are the kinds of operational things that we would like to, this was meant to just be a 101, but we do want to get into some further detail and certainly answer any questions. If you have questions that haven't been answered today, certainly you've sent some in and we'll try to answer those now. But if you have questions that you say, gee, later you're thinking and you say, gee, I would have liked to have asked that, or I should have asked that, or I was thinking about that and I didn't get to it, certainly you can send in your questions to the RA boxes on the next 2 slides. So there's one for Adult Protective Services. This one that you're seeing now is there's OPSA, and then the other one's Adult Protective Services. So, or if there's questions that you say, gee, I really want to make sure on this next webinar this gets answered, certainly send those to us as well, because we want to make sure that everyone is clear about the role of the MCOs, everyone's clear about the role of the area agencies on aging, protective service units, and certainly direct care workers, sports coordinators, and administrative staff. What is everyone's role? So we want to make sure that we're responsive to your questions. So we have received some questions, and we're going to try to see if we can go through some of these. So the first question says, does this process, particularly reporting of the 4 serious, replace Act 13 reporting? Does Act 13 reporting still apply to all ages? So just to go back over Act 13, and just for those of you who may not be familiar with the term Act 13, when the Older Adult Protective Service Act was originally written, there was no mandatory abuse reporting provision. There was an amendment to that act a few years later, and that's what people refer to as Act 13. That's what it was called at the time. We try to get away from that term, and only because it gets confusing, because there's an Act 13 of every year, and so we just got away from that, and now we're calling it mandatory abuse reporting. So just to go over just the sense of what that means. So many of you on this call are mandated reporters, and so what that means is if you suspect abuse, any abuse, you are required by law to call and report that to the Area Agency on Aging. They will then either send it to the AAA or keep it at the AAA because that's who's answering that call, or they'll send it to Liberty to investigate. If that abuse rises to one of the 4 serious, they're going to remind you, hey, by the way, you have additional reporting requirements, or hey, don't forget to call DHS for under 60, PDA, the Department of Aging for over 60, and law enforcement. And so this question says, does it take the place that I think we're just talking about the same thing, but just using a different term. So I hope that answers that question. Next question is, most agencies have one phone number staff can call out from. If an agency covers multiple counties but can only call from the agency phone number, how can you connect APS AAA how can you contact APS AAA in a certain county? For example, our agency has Cambria County phone number. If our staff work in Elk County, when they call Adult Protective Services or the AAA, will always go to Cambria County due to our phone number. How do agencies connect to the correct Adult Protective Service or AAA in the county they're calling for? So in this case, if you know you work for an agency that was just described, you can call the Area Agency on Aging directly. If you call that 1-800 line and it recognizes that you're in Elk County, it's going to Elk County. So yeah, that's a great question. I'm glad you brought that up. So in those cases where hey, we have one sort of central number and it's going to go to where we don't want it to go, you can call that Area Agency on Aging directly. Because what we don't want is, we don't want to waste time. If you suspect abuse, Protective Service wants to get out there right away. So we want you to be in contact with and collaborating with your local Area Agency on Aging. And so that's a great question. Thank you for bringing it up. Just because you brought that up, I want to say one more thing. That phone line, the 1-800 line, if it can't recognize where you're calling from, it'll default to Allegheny County. And sometimes that happens just because there's so many new exchanges. But sometimes people are out of state. Sometimes they bought their phone and their exchange on their phone is from California and it thinks you're out of state, that kind of thing. So again, for whatever reason, if that happens to you, just give Allegheny County your phone, the information you have, and they'll get it to where it needs to be. But again, great question. Yeah, if you know that you have this centralized sort of number, please, one of the things I can't stress enough is to form a relationship, an ongoing relationship, an ongoing dialogue, meetings, lunches, whatever you can do to get to know your Area Agency on Aging, because that's so important that you all become very familiar with each other. The next question says, as a mandated reporter, does this apply in the community as well? For example, I'm at Walmart and witness some type of suspected abuse. Am I required to report as I would during business hours for work-related issues? Our law is silent on that, but what I would say is that if you're just a person in this world, you're not working, you're not involved in work, you're not providing services, and you just happen to see something out on a walk, at Walmart, wherever, at that minute, you are not a mandated reporter. However, ethically, you need to report. And I think everyone on this call certainly understands and would do that for sure. I think that, it's very difficult to say to somebody you're mandated when they're not in any way working. Now, certainly certain employers would encourage their employee to report, even if they're not at work. I mean, we're all people in this world. We're all going to be adults. We all are older adults at some point. We all have loved ones who may have disabilities, and certainly we would all report. But at that minute, no, you're not a mandated reporter. You are just a concerned citizen who ethically feels that they want to report something. The next one says the Sports Coordination Agency makes a referral to Protective Service as a mandated reporter. Who is the licensing agency that we would submit the mandated report to? So I think, I don't want to answer that. I just want to make sure before I answer that I'm giving you the correct answer. So I'm going to hold on this, if you don't mind. I just want to make sure that we're all on the same page as to as to where are all the places that may need to be reported. So I'm going to hold on this one. I will make sure that we get you an answer.
The next question says, does that mean that an APS call can be called in and it will not be assigned to Liberty under 60 participants if it does not meet the criteria? I just want to make sure I cover what I think the question is answering. So the call will be called in if you utilize the 1-800 number or their local area agency on aging. That area agency on aging will take that call and then forward it on to Liberty Healthcare. Liberty Healthcare will review that information. The under 60 adult protective service law does allow them to make some additional phone calls in order to categorize. They also have access to some databases. So based off the information provided in that call and the information they obtain from key players within that consumer's life, they would then be able to make a determination of categorization. It could mean that there's another entity that's involved in that individual's life, and it doesn't necessarily meet the rise to the level that an investigation needs to be handled, and that other, whether it's service provider, whether it's another program office, will be able to address those needs for that individual. So it will be forwarded to Liberty, and then based off of the information provided and the immediate gathering information, that they will determine if that individual requires an investigation or not.
Next question says, is in regard to criminal history background checks, the provisional hiring period. Does the 30 or 90 days start from the employee's date on their work application or from the state police and DHS criminal history background check date of application? Our clock starts at the date of hire. So, for instance, if you actually read the law and the regulations, it basically says that an applicant would submit with their application a criminal history background check. Now, we're not totally holding fast to that, because a lot of applicants don't even know they need one when they walk in the door to apply. So we want to make sure that it's the date of hire, because once they determine that, hey, we're going to hire you, they often have their background check before they start then. And so date of hire for that.
The next question is, what is the protocol to handle suspected abuse if initial report to protective services at local area agency on aging did not seem to help older adults? We always encourage individuals, if they are not feeling that the protective service investigation is really reducing the risk to the individuals, first have a one-on-one conversation with that investigator, so you can be afforded the opportunity to provide your side of the story. If you continually feel that services aren't being provided according to the law, you always can contact the state agency, which would be for the over 60 would be the Department of Aging, or for the under 60 would be the Department of Human Services. On the last two slides of this PowerPoint are direct numbers that you can give a call into and then be linked up with an individual that can further discuss those concerns with you. Next question is, some AAAs tell us to send our reports to Liberty, and others tell us that they will send the report to Liberty. Which way is it supposed to be? According to the under 60 law and the way direction that we have provided, this area agency on aging should be providing both a fax number or an email where you can directly submit that mandatory abuse report. So in the event that they say to send it to their office, also ask for that additional information of they do have a direct fax number and a direct email account where those reports can be sent to.
The next question says, will you be addressing the second PowerPoint regarding service coordination and managed care? The answer to that is yes. The next question says, thank you for the clarification on the assignment of the requirement of investigation, but just to make sure I have this correct. To the SC who called it in, it may appear that there was no follow-up because there may have been other agencies that have followed up as a better place of care, or should the SC or the reporting agency find out that this was found to be better assisted through something other than Adult Protective Services? I'm not sure I understand the question, but let me give it a try. So I am a participant, I'm receiving care, there's some kind of suspected abuse, either the direct care worker, the sports coordinator, or even the MCO becomes aware of this suspected abuse. Any of those may report, but they should all make sure that the reporting is conducted. If that doesn't prohibit you from making proper referrals. If you feel that someone could receive services through an entity, that doesn't prohibit that. You still have to report under this law, but if you want to make other referrals, that's totally up to you as well. If you know somebody or an entity that can help someone or provide services that are necessary, that's great. But under these laws, you still have reporting responsibilities. I hope I answered that, but if I didn't answer that properly or that wasn't quite the question you were asking, please feel free to send to either the APS box or the OPSA box, and we'll give it another try.
I do have one question for that came in. What's the difference between calling the 1-800 number and this 717 number? If the individual who submitted this question could provide a little further information on which 717.
I think that maybe they're asking what's the difference between the hotline and the direct AAA number. Again, you can use either. We give the 1-800 line just so everyone's quick and easy. That's the number they know for all adult abuse. But if you, again, I can't encourage you enough to get to know the area agencies on aging. And if you have a direct dial to Protective Services, that's great. One question says, once CHC starts, will there only be one PS or will they still separate between ages? They'll continue to be, by law, Adult Protective Service is overseen and administered by DHS, and 60 and over is administered and overseen by aging. Laura and I work closely. I mean, Laura did Protective Services at the area agencies on aging, and then she did Adult Protective Services, and then she did older Adult Protective Services. So we work together a lot, literally daily we're together or talking on the phone. And so hopefully you'll see very little difference between our programs. Next question is an aide that has been employed at this agency since 1993 and has had a criminal background check done, which were clear. She had resided in PA since 1970, but moved to New York several weeks ago. Am I required to have her get an FBI clearance? No. Under the law, no. Under your policy, that's up to you. If you have policy about you want a new background check every year or every 5 years or upon moving or whatever, but by this law it talks about at the time of employment. And so just as an aside, we are looking at the Older Adults Protective Service Act to see if there's revisions that need to be made to address those kinds of things that have changed over time. But as the law stands today, no, but I would consider what your agency or your employer, the employer wants to do about those kinds of questions or concerns. Next question says, if there is an instance in which there are reports of psychological, verbal abuse, history of physical abuse, you perform the required reporting and receive no help from law enforcement and have had no results, how would you recommend proceeding? Is there a way to get further law enforcement involvement? Sure, if you suspect abuse, you'll be calling the area agency on aging. They, certainly we do all the time, psychological, verbal, emotional type abuse. And certainly we see, unfortunately, a fair amount of physical abuse and domestic violence. So you perform the required reporting to the Area Agency on Aging. Now, again, these people have the right to refuse, and so these might be the most difficult cases that we have, emotional abuse, interfamily abuse, that kind of thing. If for some reason you would have no results from both protective services and law enforcement, how would you proceed? If I had continued concerns or new concerns, I would make a new report. If you're not getting anywhere with law enforcement or the Area Agency on Aging, I would move up the chain of command to see if you could talk with a supervisor or a supervisor, that kind of thing. Again, you have these email boxes. If you have a concern, if anybody has a concern with anything regarding the Area Agencies on Aging, you now all have talked to me, and I'm glad to give out my direct line if there's some concern that you can't get resolved at the local level or you're having a problem with. Certainly, again, my name is Denise Getgen, G-E-T-G-E-N, and my direct is 717-772-0184. The last question on this page says, is a written report required for self-neglect or financial abuse, or just seriously bodily harm, sexual abuse, as listed on the form? So let me just think what we're being asked. So the law says that if you suspect any abuse, any and all abuse gets reported to the Area Agency on Aging. If it's one of the 4 serious abuses, serious bodily, serious physical, suspicious death, or sexual abuse, you do the oral report followed within 48 hours with a written report. So I hope that answers that question. We're going to take just a couple more. I mean, the questions keep coming in. I think that's a good thing. And we're glad to continue to answer them, but we do want to make sure that we have time for incident reporting. And so let's just take one or so more, and then we'll move into incident reporting. Last question is, if a participant passes away and Adult Protective Services was involved, will they continue to investigate? What are the steps APS determines if death was natural? So I think I can answer on behalf of Adult Protective Services and Older Adult Protective Services. The laws talk about someone who's either within the jurisdiction or is residing within Pennsylvania. And so once the death occurs, if there is a nexus between that death and the report or some suspicion that those two things are connected, there is requirements for protective services to report that to the coroner and law enforcement. And so a lot of times in those kind of very serious cases, we're already working with law enforcement. And so what will happen is sometimes we're turning things over. It depends on, for instance, if there was a concern and we were investigating something happening in a nursing home and the individual, the participant, dies, then the Department of Health in that instance, in that example, would continue on with their investigation, and we would turn it either over to law enforcement or the coroner. So unfortunately, we can't get to all the questions, and we certainly will. We will certainly either answer them in some kind of frequently asked questions, or we will answer them in the next webinar. And so I want to make sure that we have time for incident reporting, and so I'm going to turn it over to Lisa.
Thank you, Denise. My name is Lisa McDowell. I am working in the Critical Incident Management Unit for the Office of Long-Term Living, and today we're going to talk about a very important portion of critical incident reporting. And you've just heard a presentation about protective service laws in Pennsylvania. The critical incident management presentation, this one, will not directly include protective services information, but I'm going to focus on reporting, investigating, and mitigating incidents. Today's presentation for MCOs and service coordinators is a review of existing OLTL processes. As such, as each community health choices zone is rolled out, CHC MCOs will be responsible for ensuring that service coordinators and direct service providers are reporting, investigating, and mitigating critical incidents as required by regulation and by waiver language. Critical incident reporting is an important tool used to ensure providers address situations as they arise in order to assist participants to be successful in the community. OLTL's role in critical incident management will change during implementation of CHC. So OLTL will retain overall oversight of the MCOs, and the MCOs will work directly with providers to address reporting and incident investigation. We still have operational details at OLTL, and we're considering and how we're going to address this and addressing functions. One example is how will the MCO or service coordinator receive the report of need from protective services. Again, we are working on that. I would ask that you stay tuned for these details, and they should be coming together in the next couple of months, and we do anticipate a further webinar on that as well. So what is on our agenda today? The first slide, to provide context to MCOs and service coordinators about critical incident management. We'll also discuss OLTL's expectations of MCOs to assist providers to determine when a critical incident has occurred, who is responsible to report the critical incident, when an incident needs to involve protective services, how an incident is investigated, and then at the end, there's a nice little slide on reporting time frame. So why do we have critical incidents? Critical incident management is actually required by PA Code 55, Chapter 52, and also by the Medicaid waivers. It's a very important process which consists of service coordinators and providers responding to critical incidents, reporting them, investigating them, and performing follow-up. Definitions, we're going to move on to definitions. Definitions listed here from a variety of sources. Some are regulatory, some are from OLTL waiver language. Those from OLTL waiver language are based on definitions in both the CMS technical guidelines. Please note as we go through this presentation, you will also see some differences in the definitions for adult protective services and critical incidents. The definition for abuse, for example, is different for critical incident reporting and adult protective services reporting. When deciding which definitions to go to, you look at both of them. Please note that while most are identical to APS definitions, the definitions in the older Adult Protective Services Act do differ slightly. Again, check the definitions for each before deciding if it is suspected abuse, neglect, or exploitation, and it qualifies under the differing definitions. So for OLTL, the OLTL definition of a critical incident is an occurrence of an event that jeopardizes a participant's health or welfare, and it includes death, serious injury, or hospitalization of a participant. I would have you note that pre-planned hospitalizations are not critical incidents, so being admitted for a non-routine medical condition that was not scheduled or pre-planned is a critical incident. However, a routine hospital visit for lab work, or if you're going in for testing, or if you have a pre-planned surgery, that's not considered a critical incident. It is good to note that if a death is suspicious or of an unexplained cause, that is considered a critical incident. If the death is due to natural causes, it's not a critical incident. So then going back up under critical incident, we also have provider and staff misconduct, including deliberate, willful, and unlawful or dishonest activities. And later on in the slide presentation, we'll actually get into some very specific definitions for each. Going on to the next slide, under critical incident definition, it also includes abuse, which is including the infliction of injury, unreasonable confinement, intimidation, punishment or mental anguish of the participant, and abuse also includes the following: physical abuse, psychological abuse, sexual abuse, and verbal abuse. We also include neglect, exploitation, service interruption, which is an event that results in the participant's inability to receive services and that places the participant's health or welfare at risk. We also include medication errors that result in hospitalization, an emergency room visit, or that require other medical intervention. So specifics for definitions of abuse, neglect, exploitation, and other critical incidents. Abuse according to the OLTL definition, is an act or omission that willfully deprives a participant of rights or human dignity, or which may cause or causes actual physical injury or emotional harm to a participant, including a critical incident and any of the following: sexual harassment of a participant, sexual contact between a staff member and a participant, using restraints, financial exploitation, humiliating a participant, or withholding regularly scheduled meals from a participant. It is critical to note that critical incidents are not complaints. They are different, and we do have different systems to handle both of those. Complaints are dissatisfaction with program operations, activities, or services received or not received, which involve home and community-based services. Critical incidents are not program fraud and financial abuse. We do have a separate reporting mechanism for program fraud and abuse, and we do ask that you contact our Bureau of Program Integrity. And there is a bulletin that was issued on August 8th of 2011 that actually gives you different mechanisms for reporting to BPI. You can also call their 1-800 number, which is 1-844-347-8477. You can report it that way. You can report it online. They also give you information to fax it or to mail a report. And examples of program fraud and financial abuse are claims submitted for services or supplies that are not provided. And then another example is excessive charges for services and supplies. Separate reporting requirements can be found there on the bulletin, which there's a link on the DHS website. One thing that you would want to look at is a lot of times these do cross over, so it may not purely be financial abuse or program fraud. It could get into neglect and exploitation, and if it does, then that is reportable, and you want to make sure that you do that as a critical incident as well as you're reporting to BPI if it includes program fraud. Next, we have exploitation. Exploitation, the definition, is an act of depriving, defrauding, or otherwise obtaining the personal property of a participant in an unjust or cruel manner against one's will or without one's consent or knowledge for the benefit of self or others. We also have a definition for investigation. For the purpose of this bulletin, investigation means to take the steps necessary to determine if a critical incident has occurred, to determine if suspected abuse, neglect, abandonment, or exploitation requiring the involvement of protective services is needed, and what actions are needed to protect the health and welfare of participants, and what actions are needed to mitigate future incidents. Neglect is the failure to provide an individual the reasonable care that he or she requires, including but not limited to food, clothing, shelter, medical care, personal hygiene, and protection from harm. In the definition of neglect, we also include seclusion, which is the involuntary confinement of an individual alone in a room or an area from which the individual is physically prevented from having contact with others or leaving. The waivers require that service coordinators provide for the health and welfare of waiver participants, and SCs are still required to investigate critical incidents. When protective services is involved, SCs and providers are expected to cooperate with protective service investigators. And then circling back to the definition for neglect, other definitions that you should take note of include neglect and restraint. The Centers for Medicare and Medicaid Services, or CMS, which is our federal funder, issued guidance that states that policies must be in place that prohibit seclusion and use of restraint. Then restraint is any physical, chemical, or mechanical intervention that is used to control acute episodic behavior that restricts the movement or function of the individual or a portion of the individual's body. Use of restraints and seclusion are both restrictive interventions, which are actions or procedures that limit an individual's movement, a person's access to other individuals, locations, or activities, or restricts a participant's rights. And then service interruption is any event that results in a participant's ability to receive services that places his or her health and or safety at risk. This includes involuntary termination by a provider agency and failure of the participant's backup plan. these events occur, the provider agency must have a plan for temporary stabilization. Getting into reporting directly, all SCs and providers are required to report critical incidents. It is mandatory that the SC or provider agency that discovers or has firsthand knowledge of the critical incident report it. This applies to incidents that can happen at any time. Before reporting an incident, we would ask that you take immediate measures to safeguard the participant. This may include calling 911, contacting law enforcement, a fire department, or other authorities as appropriate. So what we ask is that you take care of the emergency first. If it requires CPR, calling 911, take care of that first and then worry about the reporting afterwards. Contact APS participants aged 18 through 59 or older adult protective services, participants over age 60 if the critical incident meets protective services criteria. The critical incident bulletin provides clarification that it is the agency that discovers or has firsthand knowledge of a critical incident that is required to report it. In a previous bulletin, providers could contact SCs and have the SCs report incidents for them. This is no longer permitted. All direct service providers must have access to and be trained on the Enterprise Incident Management System, also known as EIM, if they provide services in the Attendant Care, CommCare, Independence, or OVER waivers, or the Act 150 program. Direct service providers for the aging waiver must report incidents themselves to the RA box. In all cases, the individual with firsthand knowledge of an incident must make immediate measures to safeguard the participant. Actions to be taken. We would ask that you take the following steps. Safeguard the health and welfare of the participant, first of all. Determine if the incident is reportable. A critical incident has been defined above. Within 48 minutes, the SC or provider agency that discovers or has independent knowledge of the incident to submit a critical incident report to OLTL. If the incident occurs over the weekend, either enter a written report the first business day after the incident occurred. SCs must enter incidents into EIM for all but the aging waiver. SCs enter incidents into SAMS, which is the Social Assistance Management System, if the participant is in the aging waiver. And then aging waiver providers typically don't have access to SAM, so they must submit incidents to the RA incident indicated there. So this just gives you a synopsis for reporting. The first bullet is for providers. For critical incidents for the aging waivers, providers must fill out a critical incident report form and submit it by the RA incident box. And then for SCs, aging waivers, SCs must report incidents into SAM. Currently, service coordinators and providers serving aging waiver participants have a different incident reporting mechanism. However, we do anticipate that in the future, with the rollout of community health choices zones, all incidents will be eventually reported into EIM, and we are making headway into making sure that happens. All critical incidents must be documented as specified previously, and initial reports should include and must include reporter information, participant demographics, OLTL program information, event details and type, description of the incident, and then actions taken to immediately secure the participant's well-being. Providers must inform the participant's SC within 24 hours of an incident. If the participant is in need of immediate intervention, providers must immediately contact the SC if 911 is not called. Please note that direct service providers are required to report incidents not only to OLTL, but must also inform the participant's service coordinator within 24 hours of the incident. Notice to participants. We do ask that a notice to the participant be sent. The agency staff that discovered or first became aware of the critical incident is to notify the participant and the representative, if it's requested by the participant, that a critical incident report has been filed. This notice must be provided to the participant within 48 hours. If the participant's representative is suspected to be involved in the critical incident, we do ask that the representative not be notified. Within 48 hours of the conclusion of the critical incident investigation, The FC must inform the participant of the resolution and measures implemented to prevent recurrence. Investigating critical incidents. FCs are responsible for investigating reports of critical incidents that they discover or have independent knowledge of, as well as incidents submitted to them by providers. These are not protective services investigations, and they do not require protective services training. If a critical incident involves the FC or FC coordination entity, the FC or FCE should not investigate, and should turn the investigation over to OLTL immediately. The FC has 24 hours to begin investigation of a critical incident after its discovery by the FC, or 24 hours after a provider informs the FC that it has submitted an incident. FCs are to take the steps necessary to determine if a critical incident has occurred, whether it is a protective services case, and what actions are needed to protect the health and welfare of participants. The following are just general guidelines for investigations. The first one is a telephone interview, and typically you would utilize a telephone interview when you review the incident report and it reveals facts are missing or additional information is required. The information can be obtained by obtaining a telephone investigation. This slide is a little bit out of sequence because typically, the next slide, if you go to the next slide, the on-site investigation is what we recommend. With an on-site investigation, it's conducted for fact-finding, the incident facts, sequence events, interview of witnesses, and observation of the participant and/or environment is required. We do ask that if a participant is hospitalized, the SCs are to meet the hospital social workers or discharge planner or both, and the attending physician to ensure hospital staff are aware of the incident to ensure a safe discharge. If the incident is medically involved, it is recommended that a nurse or a nurse consultant accompanies the SC. Going back, no further action is required when the incident report meets all three of the following conditions. The first is that the facts and sequences of events is outlined with sufficient detail, and preventative action through the service plan is either not required or is implemented and documented, and the participant is not placed at any additional risk. So what to do after the critical incident investigation is completed? When the investigation is complete, the SC must enter the following information into either EIM or SAM within 30 calendar days of the discovery of the incident. The first are the actions taken to secure the health and safety of the participant. Then measures taken to prevent or mitigate reoccurrence of the critical incident. Changes made to the individual service plan as a result of the incident. In the case of suspected abuse, neglect, and exploitation, SCs are expected to ensure the health and welfare of participants and to cooperate with protective service investigators. When the SC is unable to conclude the initial investigation within 30 days, the SC can request an extension through EIM. And then all information of alleged incident involving a participant is confidential. Please note that if the SC has completed the investigation prior to the 30-day deadline and all of the details have been addressed, it's not necessary to wait for 30 days to complete in EIM. Policies. We do expect that all SCEs and providers develop and implement written policies and procedures relating to critical incident management. It should be in alignment with the critical incident management bulletin, which is provided at the end of the slide, at the end of the presentation. SCs and providers are to implement standard annual training for staff members providing services, which contains the following items related to critical incidents: prevention of abuse and exploitation of participants, reporting critical incidents, participant complaint resolution, department-issued policies and procedures, and providers' quality management plans. Another requirement is to show a reduction of incidents. SCs and providers are to analyze causes and trends related to critical incidents. an attempt to reduce the number of preventable incidents. The methods used by SCs and providers to reduce the number of preventable incidents are to be documented on the provider's quality management plan. The next slide is providing some resource information for adult protective services. The first bullet there is a link to the Adult Protective Services Act. It is the actual act that you can link to. And remembering that Adult Protective Services covers individuals with disabilities who are between the ages of 18 and 59. And then we also provide the 1-800 number there if you suspect abuse, neglect, and exploitation. The next slide is for older adult protective services. The second bullet there is a link to the Department of Aging Protective Services webpage. And you'll see that when you link to that webpage, there's a list of resources. It will provide you with the Older Adult Protective Services Act, Protective Services Regulations, and Protective Services Annual Report. The Older Adult Protective Services Act covers individuals age 60 and older, and then we've also included the 1-800 number there as well. And this gives you a link to the critical incident management bulletin that we are currently using. I would definitely have that, print that out. It's my daily Bible. I go to it every day. And the last slide is a nice little timeline. It gives you a synopsis of all the reporting requirements because we do have a lot of timelines within the reporting requirements. Of course, we need you to make sure that you're reporting immediately to safeguard the participant. Immediately report to protective services if you suspect abuse, neglect, or exploitation. Within 24 hours of the incident, the provider reports critical incidents to the service coordinator. Within 24 hours of the incident, the SC begins an investigation. Within 24 hours of the incident, the agency who becomes aware of the incident first notifies the participant and their rep, unless the rep is part of the allegation. Within 48 hours of the incident, the SCs and providers submit critical incident reports through EIM or through SAM. Within 30 days of discovery of the incident, the SC concludes the investigation. Remember that if you can conclude it before the 30 days, please feel free to do that. And then within 48 hours after the conclusion of the investigation, SC informs the participant of the outcome. And then, are there any questions? I have two. All right, I have one. Can you repeat that? I'm thinking it might have been for the BPI phone number, and I can actually go back through my notes here and provide you with that. But there's also a link on the DHS website that will provide you with information under program fraud and financial issue abuse. The phone number for BPI is 1-844-347-8477. But please also feel free to access that bulletin because it gives you other mechanisms for reporting. If you don't call, you can also do it via web. All right, where exactly in SAMS is the incident report? I do have that information. I came prepared with that. In SAMS, incidents can be entered as activities and referrals, and then there's an action field. And in that action field, there's actually a drop-down menu, and you can select abuse, neglect, service interruption, the various fields that you need for incident reporting. The next question is for the notice to participant. Is it a verbal notification? Is a verbal notification appropriate as long as appropriately documented, or does this need to be in writing? If you access your EIM and the incident, or when you put in the EIM, the critical incident, there's actually a field in there that you can notate that you notified the participant, and it's a yes or no. And then there's also a second one that goes down a little bit further when it's concluded. It will give you the opportunity to, did you notify them of the results, and then who you notified. So that's actually in the EIM directly, and you can document it there, and I would recommend that you do document it there. If a participant has a hospitalization and the SC agency is not informed until after DC, then the critical incident forms still need to be completed, and how would we approach this? We do ask that if it is not if it is an unplanned hospitalization, that you do report that in EIS, even if it is after the fact. You can report it that you did not receive this information until whenever you received it, but you could put in the date that they were actually hospitalized. So we do ask that you enter that hospitalization after the fact. Okay, there are no other questions. I want to thank you for joining this webinar, and we do appreciate all of the questions. Anything that has not been answered, we will follow up, and if you have any more questions, please feel free to submit them with the addresses that were given. So thank you.
Thank you.